So good afternoon. I'm Dr. Dale Bratzler. I'm the Enterprise Chief Quality Officer here at OU Health and the university's Chief COVID Officer. Today I'm going to give a brief review of where we're at in Oklahoma with COVID-19. We'll spend a little bit of time at the end talking about some of the variant strains that are starting to be identified in the United States, and also spend time talking just a little bit about the vaccination efforts in Oklahoma. So I have sent out a handout which highlights all of the information I'm sharing. As of today, Oklahoma still ranks third in the nation with respect to the population incidence of COVID-19, but I want to put that in context. Oklahoma currently has 56 cases per 100,000 population per day, which is third in the nation. However, just remember that on January 12th, we were seeing 103 new cases per day on average. So there's been a tremendous drop nationwide in the total number of new COVID cases daily, and Oklahoma has seen a very substantial drop in the number of cases. As of today, there are 399,727 cases of COVID-19, so I suspect by tomorrow we will exceed our 400,000th dose of COVID-19. 3,710 Oklahomans have lost their life. The mortality rate is actually trending up a bit because of more deaths that have been occurring. And again, I want to highlight that at 0.9% mortality rate, that's about 9 times higher than we typically see from annual influenza deaths. So again, this disease is much deadlier than the flu. There were 29 new deaths reported today. The other piece of good news I want to really highlight is that on about 3 weeks ago, we had 4,256 new cases per day on average in Oklahoma. Today we're down to 2,216. That's a 48% reduction in the total number of new cases per day in Oklahoma. So a very substantial drop in the number of new cases. A couple of points I want to make about that. So as I mentioned, we're at 2,216 new cases per day on average right now in Oklahoma. But if you look at the 7-day rolling average for the past 2 weeks, you can see that we've really plateaued. So we saw this tremendous drop in the number of cases, but now fairly consistently we're seeing between 2,200 and 2,500 new cases on a daily basis. So again, I want to highlight that just because of some really good news, a drop in the number of cases, we can't let our guard down at this point because there is still community spread of this virus, and more than 2,000 Oklahomans are getting infected every single day right now. There's still rural spread of the disease in Oklahoma. There are 5 counties, Carter, Blaine, Murray, Adair, and Comanche County, that all have more than 100 new cases per day on average per population. So there's still rural spread of the disease. However, the metropolitan counties are down quite a bit. When you look at the counties with the most cases, Oklahoma County is only seeing 42 new cases per 100,000 population a day. Tulsa County, 62 new cases per 100,000 population per day. And Cleveland County is down to 49 new cases per 100,000 population per day. So again, across the state, we've seen substantial reduction in the number of new cases, but there is still rural spread of the disease that we need to be cognizant of. The other good sign, 2 other good signs. One is the percentage of tests that are being run that are positive. So I do a simple calculation where I look at every test that's done in the state every day and what percentage of those tests come back positive. And I'll highlight that 5 weeks ago, 19% of all of the specimens tested in the state came back positive. This week so far, through 4 days, 11.4% of the tests are positive. So again, that's a positive sign. Even though we're not doing quite as many tests as we were, the percent of those tests that are coming back positive is markedly reduced now, which is a good sign that we'll see fewer cases. And then finally, I think everybody in the hospital community is super excited that we've seen this dramatic reduction in hospitalizations. We've come from January 13th around when we had just under 2,000 people in the hospital. Yesterday, there were only 951 people in the hospital with COVID-19. That's a 52% reduction in the number of hospitalizations. So again, I want to highlight that there's a lot of good news. We've really seen a reduction in the number of cases. We've seen far fewer hospitalizations now, which we would expect. We're still seeing quite a few deaths, but remember, some of the people who get really sick with COVID-19 are in the hospital for weeks before they die. And so I think we'll continue to see the number of new deaths in the state can slowly continue to come down, particularly if the hospitalization rate stays low. We just cannot quit doing the things that matter, wearing our mask, physical distancing, and washing our hands. I wanted to spend just a few moments talking about the variant strains. There's been a lot of news about the variant strains that have been identified in the country, and the CDC came out with a nice framework to think about these variant cases and why we should be concerned about them. The first is, when you have a new variant strain, does it spread more easily from one person to another? And I'll show you in just a moment. At least one of the strains that's been identified does seem to transmit between people more easily. The second, do they cause milder or more severe disease? And again, I'll highlight that one of the strains that's out now appears to have a higher death rate. Are they detected with the currently available tests that we do? The good news is in the United States that most of the PCR tests that are being done around the country will detect these variant strains, and so we're not missing cases because of that. But in some parts of the world, there are tests that don't achieve good testing for some of these variants. And then thinking about it from a healthcare perspective, when a person gets infected with one of these variants, will they respond to the treatments that we currently have that are proven to improve outcomes for people that get COVID-19? So are they resistant to the new treatments that we're using? And then lastly, the one that everybody's asking about, will the vaccines that we're giving now protect us against the new variant strains? So in the handout that I've sent out, I list the 3 variant strains that have been identified in the United States and the number of cases. The UK variant has been now identified in 33 states, all around Oklahoma. I think it's likely that there are some cases of the variant strain in Oklahoma. The UK variant is more transmissible. It spreads easier from person to person. There is some early evidence from the United Kingdom that it may be more deadly than the types of variants that we had seen in the past. And then very sadly, I saw news yesterday that there's a new spike protein mutation of this UK variant that may actually cause some resistance to the antibodies that are formed with the vaccines that we're using today. That's not proven yet, but again, it's one of the things we'll have to watch for. The second variant that's been identified, only 5 cases in the United States, is the South African variant. There are studies pending, but this variant may not respond as well, in other words, be prevented as well with the vaccines that we're given currently. But the one important thing about the South African variant is that this particular virus doesn't seem to be treated well with treatments like convalescent plasma or monoclonal antibodies that we often use when people have early COVID disease. And so again, one of the things we need to watch out for, because treatments that we have that have been shown to be helpful in patients with COVID-19 may not work as well in some of these people that develop the variant strain. And then finally, the one that perhaps scares me the most is the Brazilian variant. And this particular variant, there's only been 2 cases in the United States, both of them identified in Minnesota. So hopefully it stays that way. However, in Brazil, where this variant now has become predominant, there are a number of people who have had COVID, recovered, and then been reinfected with this new variant. In other words, both natural immunity and immunity induced by vaccines doesn't seem to prevent infection with this new Brazil variant of the disease. So the vaccines that we're giving now might not work against it, and you might even, if you've recovered from COVID, be susceptible to an infection with this new variant. So again, only 2 cases in the whole country in Minnesota, but again, we have to watch very, very carefully and think about it. So again, what it highlights for me is we can't let our guard down because the way to stop the spread of the variants is to wear masks, do physical distancing, do hand hygiene. We just have to stay vigilant at this point. Finally, I was asked to just mention something that's been kind of interesting, something called COVID arm. I have personally seen 2 cases of it now here at the Health Sciences Center, but it's widely reported in social media. So typically it's a person who received the Moderna vaccine And about a week or so after they've gotten the vaccine, they'll develop a red spot on their arm. It can get quite large. It's red, it can be inflamed, it can be a little bit painful, sometimes it itches. It is a probable just immune reaction. It's not an allergy. It actually says that your immune system seems to be reacting to something in the vaccine. It tends to happen more commonly, as I mentioned, in women. It usually occurs 7 to 8 days after the injection, so it's not something that happens real quick. Most of the time it lasts only a day or two, although it's been reported to last up for a week. It's easily treated with things like Benadryl or nonsteroidal medications. Again, it's not an allergy, and in the handout I put a picture of one of the patients I've seen that's had this COVID arm. It's widely, there are pictures all over social media now that people can pick up on, but it's an interesting side effect to warn people about, particularly if they've had the Moderna vaccine, that it may happen a week or so later. So I'll be happy to answer any questions.
And is it the Moderna arm, is that after the first and second, I mean, equally, or is it just the second dose?
Yeah, so good question. The cases that I've seen have been after the first dose of the Moderna vaccine, where the patient developed the reaction. And so some of those people that have had that will take the vaccine in the other arm, but I don't even know if it occurs more the second time. It's a new phenomenon that's been reported, but we've seen several cases here.
Okay. So thinking about some of the information that you gave us, you were talking about the testing that we're doing. And earlier this year, we worked with OMRF and OU Health, ramped up their labs so that we could do more testing. We have a more sophisticated facility or process now. Do you have any, and I'm sort of giving you this impromptu, so I don't know if you have any data on the numbers that we're able to do every day and maybe what the percentage of our testing is across, versus the state?
Well, I don't know the percentage of testing in the state. I think if you look in Oklahoma, the largest majority of COVID tests are done by commercial laboratories like DLO, Quest Diagnostic, those companies that have contracts with multiple hospitals, with multiple physician offices and others. I only know data well for OU Medicine, and we can do easily more than 1,000 tests a day. We could probably have the capacity to do a couple of thousand a day. And I think on average we've been doing 8,000 to 9,000 tests per week. So we have the capacity to do a large number of COVID tests now. But again, when you look at Roche, DLO, some of the big lab companies that have all those contracts with doctors' offices, they do a very, very large number of COVID tests in the state.
Okay. When you were talking about variants, is MIS-C considered a variant, or is that just something that happens?
Yeah, so the multi-system inflammatory syndrome that happens in children is not a variant. It is a complication of COVID-19 that occurs in children. It often occurs after the person has recovered. In fact, some parents may not even know that their kid had COVID because they didn't get them tested, but then they'll show up in the hospital, in the emergency room, with this multi-system inflammatory syndrome that's often characterized by a persistent fever. So parents should watch for some illness that consists of a persistent fever that lasts more than 24 hours. Sometimes they'll develop what looks like pink eye or conjunctivis. They'll develop skin rashes. They sometimes can have swelling of their feet or hands. There's a whole variety of inflammatory symptoms that occur, strawberry tongue, and certainly if any of those symptoms show up in a child that's been exposed to COVID, had COVID, you should certainly take them for evaluation by either their primary care or even the emergency room, because it can be very, very serious.
I had a Mason at KJRH. KJRH was asking about your recommendations for Super Bowl watch parties this weekend.
Yeah, so I have to say it, I'm a lifelong Kansas City fan. I've watched them win it twice and hope to see it for a third time. But for Super Bowl watch parties, again, kind of the same precautions we talked about for Thanksgiving and Christmas. If you're bringing people together, keep it outside if possible. If people don't live in your household, have them wear a mask. The one thing that's not a good idea is to sit around a small table where you have people without masks talking, eating, because that's how this virus spreads. This virus is largely, predominantly spread by breathing in droplets that come out of somebody else's mouth. So if you have people close together without masks, that's when virus transmission occurs. So spread people out, try to keep any events small. Don't go to large indoor parties right now. It's just not the time to do that. And keep yourself safe.
Okay, Jacqueline at News 4 would like to know what difficulties will the state see when opening up vaccinations to those with comorbidities? How will people be able to prove they have a pre-existing condition?
Yeah, so the question is about when the state moves on into phase 2 that includes people below the age of 65 who have comorbidities that put them at greater risk of COVID-19. How are we going to roll out vaccinations? I'm going to make a plea that here's where you need to get vaccine into the doctor's offices. Because if you go into a doctor's office, they almost all have electronic medical records now. They can pull the list of people between certain age groups that have comorbid conditions. They know who their diabetics are. They know who their patients are who have asthma or chronic lung disease. That's one of the ways to do it. I don't think we're going to have comorbidity police at vaccination sites to make people prove with medical records or anything else that they do have some comorbidity that might put them at increased risk. What I think will happen in most of the vaccination sites when we drop below the age of 65 is that it'll be an honor system that if you know that you're in one of those risk categories, you'll be able to go and seek out the vaccine. But again, here's where I think physicians in their offices have a distinct advantage because they know the people in their office who are at risk of the disease and need to be vaccinated.
I just got this question about the UK variant. Somebody, this person is saying some epidemiologists are predicting the UK variant will become the dominant form of the virus sometime next month. What are the implications of that happening in Oklahoma? Are our current vaccination rates sufficient to stop a new surge of a more contagious virus?
Yeah, so the question is about the UK variant and will it become the predominant strain in Oklahoma and in the United States? And I think a lot of people think that it will because it tends to spread faster. So it's easier to get from person to person, so it has that biologic advantage over the strains that had been circulating in the United States and in Oklahoma of being able to spread faster. It's in 33, it's been confirmed in 33 states now. Interestingly, in the central U.S. is where most of the states are that haven't had confirmed cases yet, but typically we see that happen, and I just think it's very, very likely that we'll see it in Oklahoma. The implications are two things. Number one, if it spreads easier, you'll have more cases. And we know that if you have more cases, you'll have more people end up in the hospital, and eventually more people will die. And then secondly, as we've talked about, at least preliminary research from the UK suggests that this new variant is more deadly than some of the other strains that have been circulating, and so we could see more deaths. So again, I think at least for the time being, it appears to be largely prevented by antibodies induced by the current vaccines. It's incumbent upon it. We're in a race. We're in a race against mutation and spread to get more vaccine into more people. So when your opportunity comes up to get the vaccine, please get the vaccine to help us slow the spread of this disease.
And I don't think you touched on this, but so even if the vaccine that we have in our system, if we've gotten vaccinated, even if, I mean, it should at least give us some protection from some of these strains, even if it's not completely, and so that maybe we don't get as sick if we get it, or is that?
Well, so certainly for the UK and the South African strain, it appears that the antibodies induced by the current vaccines are at least partially protective and maybe pretty protective against the UK strain. That's not the case with the Brazil strain, because what's happened with the Brazil strain is there's been mutations of the spike protein. The current vaccines have your body develop antibodies against spike protein. And so if that spike protein has been modified so that those antibodies can't attach to it, then those vaccines won't prevent infection with that Brazil variant of the virus. And that's what's happened in Brazil. People who have natural immunity, they had COVID, they recovered, they have antibodies. They're getting reinfected with this particular strain because their natural immunity doesn't protect them against this new strain. So again, we're in this race between getting vaccine out and reducing the total number of variants that are spreading. And the best way to stop mutations is to stop spread of the disease.
All right, this question is, Oklahoma has vaccinated nearly as many people as the number of confirmed COVID cases. Is this a sign that things are taking a positive turn for us?
Well, so I'm really excited about our delivery of vaccine. Oklahoma has been doing relatively well in the context of the total national supply of vaccine that's been provided. We've been getting it out, getting it into people's arms pretty quickly. Up to 10% of Oklahoma's population has received at least one dose, and we now know that one dose of these vaccines is pretty effective at preventing disease. It may be on the order of 70 or 80% effective at preventing infection with symptomatic COVID-19. So again, we're headed the right direction, but we need to get a lot more doses out. And I think we're going to see a lot more doses start to come into Oklahoma. I think most people are aware that Johnson & Johnson yesterday applied for emergency use authorization to the FDA. So I would expect the FDA to meet relatively quickly, review the Johnson & Johnson data, and if they feel it's sufficient, approve the Johnson & Johnson vaccine. Johnson & Johnson has already committed to making 100 million doses for the United States. It's a one-shot vaccine. Doesn't require ultra-cold storage. It's the vaccine that you're likely in the future to be able to find in a doctor's office or in a place that doesn't have that ultra-cold refrigeration.
That just reminded me of a story, an article I saw this week that had something about people in the 65 plus age should not get the AstraZeneca. Did you hear something about that? Okay, I'll have to look for that.
No,
all right, anything else? I don't have any other questions.
No, so that's the big one. I think the important thing for people to understand now is we're in a race. So if you get the chance to get the vaccine, please go get it. We really need to try to avoid some of the vaccine hesitancy that's impeded some of our efforts to get vaccines in the past. These vaccines are incredibly safe, you know, I think we're on the right path now. We're seeing this reduction in the number of cases. I think part of it's due to the number of people that have already been infected, and then we're starting to vaccinate principally the people that are 65 and older. And remember, they account for 73% of hospitalizations and 80% of the deaths in Oklahoma, so it's a high-risk population. It's why it's so important that we get those people vaccinated first. I encourage you, if you know somebody in that age group that doesn't have easy access to the internet, that doesn't know how to navigate the system to sign up for the vaccine, that doesn't have transportation, please help them because those are the people we need to get the vaccine to.